So hello, this will be my second lecture, the role of automated pupillometry in critical ill patients. And it's important for you to know that I'm a scientific advisor for Neuroptics, which is one of the company producing the pupillometry, so it's important for you, of course, when you look through my slides. So first of all, why we are interested in pupil examination in the ICU, of course, because changing in pupillary size, in particular asymmetry that we identify as an isochoria, the response to pupil to light reflex or to pain, have been largely used to predict the presence of brain dysfunction, brainstem dysfunction, and the effect of intervention to the patients. As these changes in pupillary function are used at the bedside, for example, therapies, or select, for example, for a CT scan, well, are we good to correctly look at pupillary size or look at pupillary light reflex? And this is a paper from a group in Marseille working in neuro ICU. So these are people who work dedicated and they train to take care of a brain injured patients, which have shown that if you look at the pupillometer, which is of course should be considered as the gold standard because it can optimally quantify brain size and brain reactivity when compared to the human eye, well, there is a discordance between the human analysis and the pupillometer, here in orange and red, which account to 20% of measurement. And this proportion of error increases in particular for small pupils, where it's quite complicated to adequately assess size, the presence of asymmetry, and the response to light reflex. And this data has been confirmed by other groups. So I would say that in terms of size and the response of the pupil to the light stimulation, pupillometry should be considered as the gold standard to quantify pupillary function. But the point is that if you only want to use it because assess pupillary function, this might increase cost, and we need to understand which is the role of this measurement on the patient's management. The first point, which is the area in which pupillometry has gained the most evidence, is prediction of outcome. And in particular, to predict outcome, the device, which is able, as you see here, to assess the velocity of pupillary constriction, and then the pupillary dilation, and then the amount of constriction, all these metrics of pupils. These devices, which are able to quantify all these different metrics of the pupils, still have to face the confounders in the ICU of use of sedatives and analgesics, because sedatives and analgesics will influence pupillary size, pupillar velocity, or constriction rate to the light. So if you use the pupillometer, you look at the pupillary size and the pupillary light reflex, on patients on sedatives and or analgesics, this can confound, of course, the capacity of these tools to, for example, predict outcome. This is why one company, Neuroptics, has produced an index called MPI, which is an index taking into account all the different metrics of the pupillary and the pupillary light reflex, which will give you a number very easily to quantify from 0 to 5. 0, there is no reflex to light. 5 is a perfect reflex to light. And so you have a progressive score from 0 to 5 using decimal, identifying normal response more than 3, because in healthy volunteers, healthy people, no one has a value less than 3, and pathological findings less than 3. In this case, the use of this index can allow physician, healthcare professional to get rid of the role of sedatives on the measurement of the pupils and pupillar light reflex, which of course can give robustness into the assessment of outcome. This is why in cardiac arrest patients in whom pupillar light reflex dysfunction has been associated using the human assessment to poor outcome, we have conducted this observational double-blind study in whom the role of MPI has been evaluated to see whether it could predict or not poor outcome in this patient population, around 500 patients. This paper has been published in Intensive Care Medicine 4 years ago, I would say, and it showed that alteration of this MPI less or equal than 2 already on day 1 had 100% specificity, 100% positive predicted value to identify patients having poor outcome. Of course, most of the patients with poor outcome will die without pupillar dysfunction, which means, of course, that the sensitivity is quite low, 20 to 30%. So if pupils are abnormal or pupillometry assessment, you are 100% sure that there will be no chance of future recovery. And this NPI was better than just quantify the pupillary constriction on pupillometry, and of course was much better than human assessment, in particular at day 3. And the combination of pupillometry and evocate potential in these patients had 100% specificity and around 50% sensitivity to identify patients with poor outcome. So extremely effective in this setting. And I've tried to summarize here the existing literature today with the number of patients, of course, included and the timing. And you see that with some differences, probably related to the study cohort of the cutoff chosen, the specificity to predict poor outcome is always 100%, again, suggesting the importance of this tool to strongly predict poor outcome in these patients. And in the recent guidelines, alteration in pupils, which could be assessed by the human eye, or, and this is the two here, by automated pupillometry, has been considered as a strong predictor of poor outcome in combination with other predictors in the recent guidelines of post-resuscitation care. Of course, this could also be extended in other patient populations. We have small evidence that changes in NPI over time in patients treated with VA ECMO, 50% of them because of cardiac arrest, so it's a similar result than the previous study, but 50% of those because of cardiogenic shock. The progressive alteration of NPI over time, and so persistence of low values below 3 over time, could be associated with poor outcome with a specificity of 100%. Why this study is important? Because for the first time, it underlined that when compared to cardiac arrest alone, where a single measurement, daily measurement, could be enough to assess poor outcome, repeated measurement over time and the trajectory of the patients over time will predict outcome. If you have an initially poor NPI which recover over time, you will see that 50% patients will have poor outcome and not 100%. So repeated measure of NPI is extremely important because pupil could be in some cases, of course, responsive to therapies which we would give. This is particularly true in patients with a non-anoxic brain injury, for example, TBI, in whom altered and lower NPI were significantly associated with poor outcome, and the proportion of measurement with altered NPI was also strongly predictor of poor outcome with a specificity more than 95%. According to this initial, a very interesting study, we have recently published the Orange trial. The Orange trial is again an observational multicentric study, including more than 500 acute brain injury patients, excluding those with cardiac arrest, in whom we wanted to assess whether NPI, so this index of autoregulation, could have a prognostic role. What we have observed first is that most of the measurement of NPI are within 3 and 5 and around 0. And you see that the proportion of abnormal measurement is much higher in patients with poor outcome when compared to those with, these are non-survivors, poor outcome and good outcome. So there are some patients with good outcome measurement, with outcome which will have a normal NPI measurement. But most importantly, the role of repeated measurement and the proportion of measurement in whom NPI was less than 3 was highly predictive of poor neurological outcome. One of the analyses, I will recommend you to see the supplement of this paper. We have observed also that the persistence of NPI within our normal values was a strong predictor of poor outcome, and the changes of NPI values from abnormal to normal values basically was associated with no increased risk of poor outcome. So again, the dynamic changes of pupillary function over time in these acute brain injury non-anoxic patients is a strong prediction of outcome. So it's a repeated measurement more than a single measurement very important in these patients. Of course, NPI, which is a very objective assessment of brainstem dysfunction, would not work in those patients in whom there is not a primary brain injury. We have tested NPI in septic patients, in cirrhotic patients. Because these patients have no structural brain dysfunction, the NPI has not prognostic value. So pupillometry has clearly a role to prognosticate patients with acute brain injury, anoxic and non-anoxic with the primary lesions. But also NPI is important to predict patients with increased intracranial hypertension because changes in ICP and progression of herniation to alteration of brainstem function will induce unilateral and or bilateral alteration of pupillary function, translating to a reduction of NPI. In this paper from Switzerland, 54 patients with ICP and NPI were included, and you see how NPI will progressively be reduced with an increase of ICP, and then giving osmotherapy to these patients, which will reduce ICP, will again result into increase of NPI values towards normal levels. This study from Switzerland, as this study from US, has shown that having a pathological NPI together with elevated ICP could be very interesting to see how therapies given to reduce ICP and reduce brainstem compression will act, of course, in these patients. It's a very rapid way to assess what's happening. Can NPI replace ICP? Of course, there is an association between NPI and ICP, as we have shown in this paper from our group. The first author is Chiara Roba, 100 patients with multimodal non-invasive assessment of ICP, but the area under the curve remained quite limited, 0.71. So there is a role of NPI as, I would say, a triage system to predict patients with quite great alteration of brain compliance, but NPI cannot replace ICP as an absolute value of intracranial pressure. It could be used in the future, of course, to assess whether that level of ICP is tolerated by the brain, because a level of ICP of 17 could not have the same tolerance if you have diffuse injury or focal injury. And several papers have shown, for example, when there is a midline shift, either due to brain edema or to initial ischemic stroke, there is an association between the highest midline shift and the most alteration in the NPI. So it could be really used as a tool to understand the tolerability of ICP in that individual patient. So clearly NPI could be used for brain compliance. Of course, we need more interventional studies to see how NPI react to our interventions. Together with outcome, together with brain compliance, changes in pupillary size and pupillary function are also related to cortical function, because there is a connection between the optic nerve and the optic pathways through the geniculate nuclei on the occipital areas of the cortex of the brain. So there is an anatomical connection between the optic pathways and the cortex. This explains, for example, why when we are sleeping, the pupillary size is smaller than when we are awake. And then in some patients with altered consciousness in long term, people have used video pupillometry to see how pupillary size and faster switching of the pupillary size over time is correlated with GEG activity, so a surrogate of cortical function. If you translate this to patients, which are usually sedated in the ICU, the best way to assess a potential connection between pupillometry and pupillary function and cortical function is, of course, look at the EEG. What we have done in Brussels, we have studied these more than 200 patients, anoxic, non-anoxic, and other forms of secondary brain injury. Most of them are sedative analgesics with GCSO9, in whom we looked at the EEG assessed by a blinded independent neurophysiologist and different parameters of the pupillometry. The parameter which was the most effective to separate the different levels of alteration in EEG pattern, from mild to moderate to severe and separability down to burst suppression and suppression, was the dilation velocity, which is a surrogate of sympathetic and parasympathetic function at the pupillary levels. And we have observed that this dilation velocity was extremely effective to predict a non-reactive EEG, which means severe encephalopathy, burst suppression, or suppression patterns on EEG, which are those patterns who are the most associated with poor outcome in critically ill patients, either because of brain injury or because of excessive sedation. And when you exclude anoxic patients, primary brain injuries, as TBI, SAH, or other diseases, sepsis, cirrhosis, the area under the curve to predict this non-reactive EEG was 0.92 to 0.95. So we could think in the future, and this of course should be validated in multicentric cohorts, the dilation velocity could be used as a triage system into the pupillometry to tell you whether these patients has a high risk in red, a very low risk or intermediate risk to have an unreactive EEG. Of course, you need to understand why. If it is sedation, for example, titrate down the sedative levels. If you don't have EEG to monitor the depth of sedation in these patients, to avoid over-sedation in these patients. So clearly, there could be a role to be further evaluated in assessing brain dysfunction. And the last point is that because there is an interconnection between the cholinergic pathways controlling pupillary function and those who are also associated into the occurrence of delirium in critically ill patients, there is a very elegant paper from Switzerland showing that the alteration in pupillary light reflex at day 3 was independently associated with an increased likelihood of ICU delirium. It was independent predictor corrected and adjusted for the severity of disease, SOFA score, and the use of sedatives. So it might be, again, this pupillometry, because of the connection between the pathways controlling pupillary function activity to the light and cortical pathways, it might be a surrogate to assess patients at risk of developing this kind of complication. So in the future, maybe even sedation could potentially be titrated using pupillometry, but again, these are areas in which we need more research. I didn't have the time to go more in depth because I didn't want to be too long and to give you too many information, but there is a role for pupillometry to potentially assess autonomous nervous system dysfunction, to potentially predict delayed cerebral ischemia. Here the data are more controversial. Even in patients with seizure, pupillometry, in response to antiepileptic drugs, pupillometry has been studied with some very early and preliminary promising results. And of course, the pupillary dilation to pain stimulation has been already implemented in clinical practice in some countries in whom titration of analgesics has been done based on pupillometry, which will reduce the postoperative pain, which also, of course, is one of the predictive factors for postoperative delirium. So I would say that globally, pupils should be seen as a vital sign together with heart rate, blood pressure, oxygen saturation, respiration, and temperature, in particular for patients who are sedated, who are high risk of brain dysfunction, who have a primary brain injury. Pupils is definitely something we need to implement at the bedside, together with the standard GSS or very gross neurological examination that we do. And pupillometry should be part of the large armamentarium of neuromonitoring we have at bedside. Very easy to implement, very easy to use, very friendly use. It will give some information which are very easily to understand, and together with other neuromonitoring tools should be implemented in this multimodal approach to better understand the principles of brain dysfunction in different critically ill conditions and potentially help to titrate therapies and to predict prognosis. Thank you a lot for your attention.